Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Asfian Muhammad Zubairi, and we are going to discuss about neurogenic bladder today. So the objectives of this presentation are we will go through history and clinical examination after a brief introduction. We will discuss about etiology, diagnosis, and conservative treatment, which includes bowel management, physiotherapy, continent devices, bladder drainage, CISC, and drugs. So, a brief introduction. A urinary bladder, as we all know, is a visceral, smooth muscle organ, and it is under voluntary control from the cerebral cortex. Normal bladder function requires coordinated interaction of efferent and efferent components of both the somatic and autonomic nervous systems. Many levels of the nervous system are involved in regulation of voiding function. Therefore, neurologic disease can cause changes in bladder function. A normal bladder capacity is around 400 to 500 ml and without appreciable increase in intravesical pressure. When the sensation of fullness is transmitted to the sacral cord through the efferent fibers, the motor arc of the reflex causes a powerful and sustained detrusor contraction and urination. If voluntary control is lacking, as in infants, it occurs. So this is inhibited in young children as myelinization of CNS progresses, and they can urinate whenever it is appropriate. So we just have a overview of the nervous supply of the urinary bladder. Sorry. So we can see the sympathetic fibers. Usually contracts the internal sphincter and help in retaining the urine. Parasympathetic fibers, they relax the internal sphincter and contract the detrusor and help in urination. And the pudendal nerve, it relaxes the external sphincter and voluntarily patient can void by this mechanism. So this is a brief overview of the mechanism of micturition. The stretch receptors when the bladder is full, the sensation of fullness uh, comes the bladder, the stretch receptors of the detrusor, they detect filling of the bladder and the efferent signals are transmitted to the spinal cord. As we can see here, they come to the spinal cord and the signals then they return to bladder from the spinal cord. Segments S2 and S3 via parasympathetic fibers in the pelvic nerve and efferent signals they excite the detrusor muscle here and the efferent signals also relax the internal urethral sphincter over here. And urine is involuntarily voided if not inhibited by the brain. So this is what usually happens in infants who lack voluntary control. So for voluntary control, the micturition center in pons here. The signals from stretch receptors they go to the micturition center in pons, and if it is timely to urinate, pons return signals to the spinal interneurons and excite detrusor and relax internal urethral sphincter and urine is voided. And if it is untimely to urinate, as in here, so the pons excite spinal interneurons and keep the external urethral sphincter contracted over here. And urine is retained in the bladder. And whenever it is appropriate, timely to urinate, signals from the pons they cease and external urethral sphincter relaxes and urine is voluntarily voided. So now coming to the history. History taking in such patients should include past and present symptoms and disorder. If in non-traumatic urological patients with insidious onset, a detailed history may find that the condition started in childhood or adolescence. It consists of both urinary storage and voiding symptoms. So in urological history, we should inquire about the onset of symptoms and is there any relief after voiding to detect the extent of lesion in absence of obstructive uropathy, bladder sensation, initiation of micturition, about whether patient strains or not, the stream if it is intermittent, history of catheterization, CISC, frequency of the voided volume, and incontinence and urgency episodes. So, bowel history is important as these patients may have neurological bowel dysfunction as well. So, we should inquire about the frequency of defecation, fecal incontinence or soiling of clothes, and is there a desire to defecate, defecation pattern, sensation. So, this is a Bristol stool chart, and by this tells us that there are 7 types of stools. Um, Type 1, usually there are separate hard lumps. Type 2, it is lumpy and sausage-like. Type 3, it is sausage-shaped with cracks in the surface, which is normal. And type 4 is sausage-like. Type 5 is soft blobs with clear-cut edges. And type 6 is mild diarrhea. Type 7 usually occurs in severe diarrhea, which is liquid consistency, no solid pieces. This is a bowel diary that such patients are given that they can fill. In this, they have to mention the date, time of defecation, amount roughly, and the type of stool that they are passing, and any other forms. So, patient history after urological bowel, we should also inquire about sexual functions of the patient. They may be impaired, and we have to inquire about any sensation in genital area, the lack of erection, lack of orgasm or ejaculation, and in females, we can inquire about dyspareunia. In neurological history, where we should inquire about any acquired or congenital neurological conditions, mental status of the patient, comprehension, somatic or sensory symptoms, any spasticity or autonomic dysreflexia. We will go through this later in this presentation. Any function, body function, limb movements, mobility. In past history, we have to ask about any hereditary or familial risk factors, age of menarche in females, any obstetric history in females, history of diabetes, neurological diseases, accidents, operations involving CNS and spine. In present history, we can ask about any medication that they're taking. And in personal history, we have to ask them about their lifestyle, smoking, drugs, alcohol, sexual and moral function, as we have gone through this earlier, and the quality of life. So, physical examination. The neurourological status should be described as completely as possible. Patients with a high spinal cord lesion or a suppressed spinal lesion may suffer from significant drop in blood pressure when moved into a sitting or standing position. The sensations and reflexes in urogenital area must be tested, including anal sphincter and pelvic floor muscles. In physical examination, we should also test the sensations and reflexes mediated through lower spinal cord, the limb reflexes, which help us to further localize the site of lesion. So this is a dermatomal supply of the perineum lower body. We can see the root values of various reflexes. The cremasteric reflex comes from L1 and L2. The knee reflex from L2, 3, and 4. Ankle reflex S1, S2. The bulbocavernous reflex is S2, 3, and 4. And anal reflex is S2, 3, 4, and 5. So on the top left, you can see the cremasteric reflex, in which you have to move, so touch the medial side of the thigh and see this ipsilateral testes go up by the contraction of the cremasteric muscle. And on the top right, you see the bulbocavernous reflex. In bulbocavernous reflex, the glans is squeezed and the fibers they go up to the spinal cord and cause external anal sphincter contraction. In females, this is done by squeezing the clitoris and the same reflex arc. anal sphincter contracts. This is the anal reflex, in which a pointed object is touched toward the anal sphincter, and it brings about the contraction of the sphincter. So autonomic dysreflexia is a sudden exaggerated autonomic response to various stimuli in patients who have spinal cord injury or spinal dysfunction. This generally manifests at or above the level of T6, and it is defined by an increase in systolic blood pressure of more than 20 millimeters from baseline, and this can have life-threatening consequences if not properly managed. The stimulus for causing autonomic dysreflexia could be a distended bladder or a bowel, bloated bowel. Iatrogenic stimulus during cystoscopy or UDS can trigger autonomic dysreflexia. So, physical examination, we need to test sensations, reflexes of the patient, bulbar awareness, perianal, anal, near reflexes, limb reflexes, anal sphincter tone, and palpation of the prostate by DRE. EAU recommends the history taking should be extensive, general history, concentrating on past and present symptoms, and specific history for each of the functions of the urinary bladder, urological, bowel, sexual, and neurological history components should be included. And we should pay special attention to existence of alarm signs such as pain, infection, hematuria, fever, and we should assess the quality of life. There are various quality of life questionnaires, tools available. And for physical examination, we should acknowledge individual patient disabilities when planning further investigations. Describe the neurological status as completely as possible, and sensations and reflexes in urogenital area must all be tested. Should test the anal sphincter tone, pelvic floor functions, and perform urinalysis, blood chemistry, bladder diary, residual free flowmetry, incontinence, quantification, and urinary tract imaging. So the neuro-urological symptoms, they depend predominantly on location and extent of the neurological lesions. They are divided into suprapontine, infrapontine or suprasacral, and sacral or infrasacral. Suprapontine lesions usually occur due to cerebrovascular accidents, dementias, Parkinson's, brain tumors, cerebral palsy, traumatic brain injury, or hydrocephalus, non-nutrition. In infrapontine, infrapontine or suprasacral lesions, we have spinal cord injuries, spina bifida, and in sacral and infrasacral lesions, we have degenerative diseases, disc prolapse, lumbar canal stenosis, iatrogenic pelvic nerve lesions, and disseminated central disease includes multiple sclerosis. Peripheral neuropathy can also be the cause, and diabetes, alcohol abuse, genital herpes, Guillain-Barré syndrome, they can all contribute to neurogenic neurological issues. So when diagnosing neurourological symptoms, the aim is to describe the type of dysfunction. A thorough medical history, physical examination, and bladder diary are mandatory for any additional diagnostic investigation. Early diagnosis and treatment are essential in congenital and acquired neurological disorders to prevent irreversible changes within the lower urinary tract. Neurological symptoms can be the presenting feature of neurological pathology, and early intervention can prevent irreversible deterioration of lower urinary tract and upper urinary tract. So this is a diagram which tells us about suprapontine lesions. The history that the patient was lived with predominantly includes storage symptoms. And on ultrasound, there would be insignificant post-void residue. And on urodynamics, we may find blood vessel overactivity. So we have a small diagram for remembrance. Overactive bladder So spinal or infrapontine supracerebral lesions. History would be mixed, storage and voiding. And ultrasound could give us post-void residue, and urodynamics will give us detrusor core activity and detrusor sphincter dyssynergy. In sacral and infrasacral lesions, history would be predominantly of voiding symptoms. Ultrasound would give us a raised post-void residue, and on urodynamic we would see a hypocontractile or acontractile. So, bladder diaries. They provide us the data on the number of voids, voided volume, pad weight, incontinence or urgency episodes, and a 24-hour bladder diary for at least 3 consecutive days is reliable. No research has been done on bladder diaries in urological patients according to guidelines. Nevertheless, bladder diaries are considered a valuable diagnostic tool. So this is a bladder diary, a sample in which the patients have to mention the drinks, the kind. This upper row is filled sample. So what the patient had, how much did the patient had, and then urinary about urine, how many times did the person go to the washroom in 2 hours, in an hour, and about how much did the patient void. There accidental leaks. If it's a small, you have to take care, medium, large, and then about accidents, the patient has to tell about whether they felt a strong urge to urinate or what were they doing at that time. So primary aims for treatment of urological symptoms are to protect the upper tract and achieve or maintain maintenance of continence and restoration of lower urinary tract function and improving the quality of life of the patient. These are the primary aims for managing such patients. So on conservative management, we have different ways that can help the patients keep their bladders empty. So one of them is bladder expression, in which a downwards movement of the lower abdomen by suprapubic compression, this is called Creed's maneuver, or by abdominal straining, such as Valsalva, leads to an increase in intravesical pressure and causes reflex sphincter contraction. And their use should be discouraged unless UBS show that the intravesical pressure remains within safe limits. The intravesical pressure rises, then we should not allow patients to do these maneuvers. In long term, pelvic floor weakness may increase, further causing exacerbating stress and incontinence. This is a pictorial representation of Creed's suprapubic compression would lead to bladder empty. So another method is triggered reflex voiding, in which the sacral or dermatomes in that patient are stimulated. This is for patients with upper motor neuron lesions. This can elicit a reflex detrusor contraction. In this, we have a risk of high pressure voiding, and interventions to decrease outlet resistance may be necessary. Triggering can also induce autonomic dysreflexia that we have gone through earlier, in which the systolic blood pressure would rise more than 20 millimeters from the baseline. So this usually autonomic dysreflexia usually occurs at the level above T6. So triggering can also induce autonomic dysreflexia. And all assisted bladder emptying techniques require low outlet resistance. Even then, high pediatric may still be present. So patient education and close urodynamic and urological surveillance is required. There are other external appliances that can be used to manage patients' dry, such as social continence can be achieved by collecting urine during incontinence by using pads or condom catheters with urine bag, which are a practical method for men. Penile clamp is contraindicated in case of detrusor overactivity or low bladder compliance because of risk of developing high intravesical pressure and pressure source necrosis in case of altered absorption decisions. So we can see these are pads for social incontinence, condom catheters, and penile clamp. So drugs, in this we don't have a optimal therapy for single optimal therapy for neurological patients always available. Therapies include antimuscarinics, intermittent catheterization. Aim, as we have stated earlier, is to prevent upper tract damage and improve long-term outcomes. So, antimuscarinics are the first line choice for treating neurogenic reclusal overactivity by inhibiting the parasympathetic pathways. They cause increase in bladder volume and reduce episodes of urinary incontinence. Oxybutynin is commonly used. Trospium, tolterodine is also used, and propylene are established, effective, well tolerated, even in long term. Darifenacin and solifenacin have shown similar results in patients with neurogenic reclusal overactivity secondary to spinal cord injury or multiple sclerosis. In conservative management, drugs also include beta-3 adrenergic agonists such as mirabegron in spinal cord injury and multiple sclerosis patients. It has not demonstrated significant effect on reclusal pressure or systometric capacity in short term. However, improvement of lower urinary tract symptoms has been reported. Significant improvement in overactive bladder symptoms with lower doses of mirabegron have also been reported. For avoiding symptoms, drugs include methanecol, diastigmine. They have been considered to enhance reclusal contractility and promote bladder emptying, but are not used in clinical practice. Preclinical studies have demonstrated improvement in bladder contractility with intravascular cannabinoid agonists. Alpha blockers such as tamsulosin, naftobidil, and silodosin seem to be effective in decreasing bladder outlet resistance post-bed residue autonomic disturbance. For increasing bladder outlet resistance, there are no high-level evidence studies in neurological patients. The recommendations are to use antimuscarinic therapy as the first-line medical treatment for neurogenic reclusive overactivity, and to prescribe alpha blockers to decrease bladder outlet resistance, and should not prescribe parasympathomimetics to underactive reclusives. Catheterization: patients who cannot empty their bladder effectively, they need intermittent self or third-party catheterization. Sterile intermittent catheterization significantly reduces the risk of UTI and bacteriuria as compared with clean intermittent catheterization. The average frequency of catheterization is 4 to 6 times. The catheter size most often used is 12 to 16 FR. Bladder volume at catheterization should not exceed 400 to 500 ml. We should do recommendations are to use intermittent catheters wherever possible. Aseptic technique as a standard treatment for patients who are unable to empty their bladders. Thoroughly instruct patients in the technique and risks of intermittent catheterization. And avoid indwelling transurethral and supraorbital catheters whenever possible. Thank you.